Welcome to the Deep Dive, your weekly shortcut to being well-informed, where we take complex academic concepts and, well, we break them down into essential, memorable insights.
And today we are tackling a huge one, a really deep dive into the intricate histology of the human eye.
It's arguably one of the most, mechanically and biologically sophisticated organs we have.
Absolutely. And when you look at its design, it's easy to see why the classic textbook analogy always compares it to a high-end digital camera.
That analogy really does set the stage perfectly, doesn't it?
It does.
You have this protective, transparent front end, the cornea and the lens, and they work together as the optical system.
Right, to capture and focus the light rays.
Then you've got the iris, acting exactly like the camera's diaphragm, dynamically adjusting the pupil size to regulate the exposure.
And of course, the heart of the whole system is the retina, that dense layer just packed with photoreceptor cells.
The CCD.
Precisely. It functions exactly like a charge-coupled device. It detects the light intensity, the color, and converts those wavelengths into electrical language for the brain.
But we're going much deeper than just that snapshot today.
Oh, much deeper. We're going to systematically navigate the microscopic and the gross anatomy, following the exact structure of this histology chapter. The goal is to make sure you grasp all the most critical structures, from the outer protective coats to the inner neural circuits.
Because what that textbook comparison often misses is that the eye is, it's fundamentally more elaborate than any camera.
It really is.
It doesn't just passively wait for a photo op. It's actively tracking moving objects through these precise, coordinated movements.
Governed by those 6 extrinsic muscles.
And the key to our whole world is that we have 2 of them, which lets our occipital lobe integrate those 2 slightly overlapping perspectives.
And that integration process, known as stereopsis, is what gives us our perception of 3D depth and distance. It's a true marvel of biological engineering.
Okay, so to appreciate that marvel, where do we start?
We start with the physical framework. The eye is a near-perfect sphere, roughly 25 millimeters in diameter, and it's suspended securely within the bony orbit.
And that suspension, along with the generous cushioning from that thick layer of orbital fat, that's what enables the smooth tracking movements.
Exactly. Now, the physical wall of this sphere is constructed from 3 very distinct concentric layers or coats.
Okay, so 3 layers. We're going from the outside in.
We are. From the tough outer fibrous layer, through the middle vascular and pigmented layer, and then finally to the incredibly complex sensory inner layer.
Let's start with the outer one then.
Okay, externally we find the corneoscleral coat. This is the outer fibrous protective layer.
Right.
And it's mostly composed of the opaque white sclera, which is a dense, irregularly arranged fibrous connective tissue.
So its main job is just protection and structure.
Protection, structure, and providing those essential attachment points for the 6 extrinsic muscles we just mentioned.
And wrapping over the very front of that, the anterior 1/6, that's the transparent part, the cornea.
Exactly. It's structurally continuous with the sclera, but functionally it's radically different.
And the sclera's appearance has some interesting clinical details, right?
It does. When the sclera is thin, like in children, the underlying pigment in the choroid can sometimes give it a bit of a bluish tint.
Okay. And in the elderly?
Conversely, in the elderly, you get an accumulation of the, wear and tear pigment lipofuscin.
Which can make it look yellowish.
That's right. But the color change everyone recognizes is scleral icterus.
Jaundice.
Right. If you can picture the white of the eye turning that distinct yellow, what you're seeing is elevated levels of circulating bilirubin. It's a hallmark of liver dysfunction, which makes the sclera a vital diagnostic window.
So moving inward, we hit the middle layer.
The vascular coat, also universally known as the uvea. And this coat is just densely packed with blood vessels and pigment. The posterior portion is the choroid.
And it's intensely dark brown, almost black. Why is that pigment, that melanin, so critical there?
Well, it acts like the black paint on the inside of a camera box. Its primary job is light absorption.
I see. To reduce glare.
Exactly. By absorbing stray light that passes through the retina, the melanin minimizes internal reflections, which keeps the image crisp. The choroid is also extremely rich in venous plexuses and capillaries, and it's firmly attached to the retina, supplying critical nutrients to those outer retinal layers.
And as the uvea moves forward, it changes.
It differentiates into the specialized structures of the anterior eye. So first we encounter the ciliary body, which is a ring-like thickening.
And this is the muscular powerhouse. This is what's responsible for changing the eye's focus.
Absolutely. The ciliary body contains the ciliary muscle. It's smooth muscle tissue that governs lens accommodation. It allows us to dynamically change the shape of the lens to keep light rays perfectly focused on the retina.
Whether we're looking at a mountain or, a book right in front of our face.
Precisely. And finally, the most visible part of the uvea is the iris,
The colored part of the eye.
the colored part. This beautiful structure is the contractile diaphragm. It's packed with smooth muscle fibers and pigment cells, and its sole function is regulating the size of the central opening, the pupil, to adapt to changing light.
So those three coats, the corneoscleral, the uvea, and the retina, they define the internal spaces, right? The chambers.
The three critical fluid-filled spaces, yes.
Okay, let's visualize those.
First, you have the anterior chamber, which is situated between the back of the transparent cornea and the front surface of the iris.
Okay.
Then there's the smaller posterior chamber, a tight little space nestled between the posterior surface of the iris and the anterior surface of the lens.
And then the big one.
And then the truly massive space filling the posterior 4/5 of the globe, the vitreous chamber. This is bounded by the back of the lens and the delicate neural retina.
And anatomists often divide the eye functionally, don't they?
They do. The anterior segment is basically the cornea and those two chambers, anterior and posterior.
Oh, yeah.
The posterior segment is everything else, the vitreous chamber, the retina, the RPE, and the posterior parts of the uvea and sclera.
Now, for light to actually reach the photoreceptors and form an image, it has to pass through 4 transparent materials.
The refractile media, they all work to bend or alter the light's path.
And the most important of these is the cornea.
By far. It provides the majority of the bending power, about 80% of the eye's total refractive power. Given its shape and its high refractive index of 1.376, it's the non-adjustable primary focusing element.
And next?
Next is the aqueous humor. This watery fluid circulates through the anterior and posterior chambers.
Its role in refraction is minor, I assume?
Very minor, but its physiological role is immense. It delivers essential nutrients and oxygen to the avascular cornea and the lens, which, can't be supplied by blood vessels.
Third is the lens itself. Transparent, biconvex, and suspended delicately in place by the zonule of Zinn.
And it provides that fine-tuning capability. Because it's elastic, its shape can be dynamically adjusted by the ciliary muscle to achieve accommodation.
And finally, filling the largest space is the vitreous body.
Often called the vitreous humor. And this isn't just a simple liquid, it's a transparent gel.
Made of what?
It's primarily 99% water, but it's stabilized by collagen fibrils and these large molecules of hyaluronan. It maintains the globe's shape, acts as a shock absorber, and keeps the neural retina in gentle contact with the RPE layer.
Okay, so understanding how all of this develops embryologically is key to grasping the relationships between these coats.
It is, especially when it comes to how nutrients are delivered and how the neural layers are organized. We need to remember that eye tissues come from 3 distinct primary embryonic sources.
Right. What are they again?
The 3 foundational components are the neuroectoderm, which forms the brain-derived structures, the surface ectoderm, which forms skin-derived structures, and the surrounding mesoderm, which gives rise to the connective tissues and muscles.
So let's track the milestones. Very early on, around day 22 in the developing brain.
You get these shallow indentations called optic sulci appearing in the neural folds. These quickly bulge out to form the optic vesicles, which stay connected to the forebrain via the optic stalk.
And at the same time, the surface ectoderm right on top of this vesicle thickens into the lens play code.
Exactly. And the next step is a profound change in structure, invagination. Both the optic vesicle and the lens placode fold inward.
Creating a nested, double-walled structure.
The double-layered optic cup.
And those 2 layers of the optic cup dictate the future of the retina.
They do. The inner, thicker layer becomes a complex neural retina with all our photoreceptors and neurons. The outer layer becomes the single-cell sheet of the retinal pigment epithelium, or RPE.
And the mesenchyme around this developing cup condenses to form the protective sclera.
Right. And the lens completes its separation pretty early. The invaginated lens placode seals off to form the lens vesicle, and it detaches completely from the surface ectoderm by the 5th week.
And what's fascinating is that the surface ectoderm then rethickens to form the final, durable corneal epithelium.
It does. And then mesenchymal cells infiltrate to generate the rest of the corneal layers, like the stroma and endothelium.
But to bring supplies to this whole structure, you need a pathway.
You do. A groove, the choroid fissure, develops along the inferior surface. This allows the hyaloid artery and vein to penetrate the interior, supplying the inner chamber and the developing lens.
But that artery is temporary, isn't it?
It is. Its distal part eventually degenerates, but the proximal parts persist, forming the vital central retinal artery and vein, which we'll see are essential for nourishing the inner retina.
And we see pigmentation starting early in the RPE. The fundamental neural layers, the photoreceptors, bipolar cells, ganglion cells, they're all established by the 7th month of gestation.
But here's a detail that often surprises people. The area designed for maximum clarity, the macular depression, which becomes the fovea centralis,
It's a late bloomer.
a very late bloomer. It only begins to develop around the 8th month of gestation, and its maturation isn't fully complete until about 6 months after birth. It just highlights that the ultimate fine-tuning of sight happens outside the womb.
The accessory structures also show their neuroectodermal origin. The ciliary body and the iris form from the anterior rim of the optic cup.
And those all-important muscles that control the pupil, the sphincter and dilator pupillary muscles, are derivatives of the neuroectoderm, specifically that outer layer of the optic cup.
Okay, so let's move to the detailed microscopic anatomy, starting with that outer fibrous coat again.
The cornea, which is a triumph of biological physics. It's responsible for most of our focusing power, and its dual requirements, mechanical strength and perfect transparency, are met by 5 highly organized layers.
5 layers. Okay, let's walk through them. What's layer 1?
Layer 1 is the corneal epithelium. This is a non-keratized, stratified squamous epithelium, typically 5 cell layers deep, and it's structurally continuous with the conjunctival epithelium. It's highly regenerative.
How regenerative?
It can replace itself completely in about a week.
Wow. And where does that rapid regeneration come from?
It's powered by the corneal limbal stem cells, found right at the limbus, which is that transitional zone where the transparent cornea meets the opaque sclera.
And the cornea's mechanism for dealing with UV light is really surprising.
It is. Instead of using melanin, which would obviously block light, the epithelial cells use nuclear ferritin for UV protection.
And its extreme sensitivity also comes from this layer.
Saturated with free nerve endings, one of the most reactive surfaces in the body.
Okay, layer 2.
Layer 2 is the Bowman membrane. It's a homogeneous fibrillar layer that offers significant mechanical strength. However, and this is key, if this layer is damaged, it does not regenerate.
It forms a scar.
An opaque scar, which is why it's such an important barrier against microbial infection.
Next is layer 3, the thickest layer by far.
The corneal stroma, or substantia propria. It makes up about 90% of the cornea's thickness.
And what's it made of?
Primarily flattened fibroblasts, or keratocytes, interspersed among about 60 thin lamellae of collagen bundles.
And this stroma is the absolute key to transparency.
It is. If you could see it microscopically, you'd understand why. The collagen fibrils are incredibly uniform in size, precisely 23 nanometers in diameter. And more importantly, they are arranged in an orthogonal array.
Meaning at right angles.
Successive lamellae alternated at right angles.
Oh.
And transparency is maintained because the spaces between these uniform fibrils are smaller than half a wavelength of visible light. This regularity ensures minimal scattering.
So if the cornea swells up.
The geometry is disrupted, the spaces increase, and you get opacity. Haziness.
Okay, layer 4.
The descendant membrane, the posterior basement membrane. This is the basal lamina of the endothelium. Unlike Bowman membrane, it's very thick, up to 10 micrometers. And if damaged, it readily regenerates.
And there's an interesting clinical marker here.
Yes, in cases of Wilson disease, where you have excessive copper accumulation, those copper deposits often localize right within the descendant membrane, showing up as the distinctive gold-brown Kaiser-Fleischer rings.
And finally, layer 5.
The corneal endothelium, a single layer of squamous cells facing the anterior chamber. Since the cornea is avascular, this layer is the primary metabolic exchange site.
And it has a powerful pump.
A very powerful Na plus K plus activated ATPase pump. Its function is crucial. Detergescence. It actively pumps water out of the stroma and back into the aqueous humor, maintaining the low water content required for transparency.
So if this endothelium is damaged,
That function fails, you get rapid corneal swelling and opacity. And since these cells have limited ability to proliferate in humans, severe damage often requires a corneal transplant.
Okay. Juxtaposed against the transparent cornea is the opaque, thick sclera.
And the reason for the opacity is simply a matter of organization. The scleral collagen fibers are irregularly arranged and vary greatly in diameter. No order.
And this brings us back to the corneoscleral limbus, the junction we mentioned earlier. It's not just home to stem cells.
It also houses the vital drainage system for the aqueous humor, located at the iridocorneal angle.
Let's trace that pathway because it's essential for maintaining eye pressure.
Right. Aqueous humor, generated by the ciliary body in the posterior chamber, flows through the pupil into the anterior chamber. From there, it has to drain through a highly labyrinthine sponge-like structure,
The trabecular meshwork.
also known as the spaces of Fontana. Once it's filtered through the meshwork, the fluid collects into a large circumferential channel called the scleral venous sinus.
The canal of Schlemm.
Exactly. From the canal of Schlemm, the fluid is carried away by smaller collecting vessels, the aqueous veins of Asher, which ultimately connect back into the general venous system.
And this drainage system is everything. If it's impeded, we get glaucoma.
The clinical correlation explains that sustained increased intraocular pressure, or IOP, is the hallmark of the disease. And because the eye wall is inelastic, this pressure compresses the retinal nerve fibers.
Leading to atrophy that shows up as optic disc cupping.
Right. And there are two major mechanisms for this obstruction. The most common is open-angle glaucoma, where the angle itself looks open, but the physical obstruction is internal, within the trabecular meshwork itself.
And the other type.
Angle closure glaucoma, which is more severe and acute. Here, the angle is physically narrowed or blocked, which acutely obstructs the inflow to the canal of Schlemm. This can cause rapid, severe pain and potential blindness if not treated immediately.
And treatment is all about lowering that IOP.
Entirely. Usually with pharmacological agents like prostaglandin analogs, which increase drainage, or carbonic anhydrase inhibitors, which decrease production. And then there are surgical interventions like laser trabeculoplasty or iridotomy.
Let's move deeper now into the vascular coat, or uvea, starting with the iris.
Right, the most anterior part. It functions as a highly vascularized connective tissue stroma, and it's covered posteriorly by a dense double layer of pigmented epithelium.
And the pupil regulation here is fascinating, with two opposing muscles.
Both derived from neuroectoderm. First, the sphincter pupillae muscle forms a circular band right near the pupillary margin.
And that's controlled by the parasympathetic system.
Correct. Via cranial nerve third, the oculomotor nerve. When it contracts, it reduces the pupil size, a process called meiosis.
A fixed and dilated pupil is a very bad sign.
It's a critical clinical sign of severe neurological distress, indicating a loss of that parasympathetic control.
And the opposing muscle.
The dilator pupillae muscle. This is a thin radial sheet of contractile processes that actually belong to the anterior pigment myoepithelium.
And this one is controlled by the sympathetic nervous system.
Right, fibers from the superior cervical ganglion. Its contraction pulls the pupil open, causing dilation or mydriasis.
Which is why they give you eye drops before an exam.
Exactly. Mydriatic agents like atropine temporarily paralyze the sphincter muscle, forcing the pupil open so we can get a good look at the retina.
And just quickly on eye color, it's determined by the density of melanocytes in the iris stroma.
It is. Low melanocyte counts mean we see light reflected off the posterior RPE layer, which results in blue eyes. As the count increases, the color shifts to green, gray, and then brown.
Continuing posteriorly, we get to the ciliary body.
A thickened ring of tissue between the iris and the choroid. Its surface features about 75 radial ciliary processes.
And the bulk of it is the ciliary muscle, with 3 functional groups.
Correct. You have the outer meridional fibers, which stretch the choroid, then the radial fibers, which flatten the lens for distant vision.
And the innermost group.
The circular fibers, which act like a sphincter. When they contract, they relieve tension on the suspensory ligaments, allowing the lens to become rounder for near vision. That's accommodation.
And the surface of the ciliary processes is covered by the ciliary epithelium.
A double layer that's a continuation of the retinal epithelium, and it has 3 essential tasks.
Let me guess. 1 is secreting aqueous humor.
That's number 1. Number 2 is maintaining the blood-aqueous barrier via tight junctions. And third, secreting and anchoring the zonular fibers that suspend the lens.
Our final structure in the uvea is the choroid.
The dark brown, highly vascular sheet lying deep to the retina. The most functional layer is the inner choriocapillary layer, a dense network of fenestrated capillaries.
And because they are fenestrated, they are highly permeable.
Which is how they provide the sole nutrient source for the outer retinal layers, especially the very metabolically demanding photoreceptors and the fovea.
And separating this layer from the retina is the Bruch membrane.
A highly resilient multi-layered structure. Under an electron microscope, you'd see it's composed of 5 distinct layers. Elastic and collagen fibers sandwiched between the basal lamina of the RPE and the capillary endothelium. It's a tough, critical boundary.
Which brings us to the retina itself, the innermost sensory layer.
Derived from the embryonic optic cup, giving it that unique 2-part structure. The complex neural retina on the inside, and the single protective layer of the retinal pigment epithelium, RPE, on the outside.
And critically, a potential space exists between these 2 layers.
The vestige of the original embryonic space. And if they separate, that's a crisis.
Retinal detachment. An emergency because the photoreceptors suddenly lose their exclusive nutrient supply from the choriocapillary plexus.
It leads to rapid necrosis and, if untreated, blindness. Patients often describe seeing a shower of pepper, which is often red blood cells, along with floaters or flashes of light.
And repair usually involves laser photocoagulation.
Exactly, to create controlled scarring that basically welds the neural retina back to the RPE.
Okay, so within the photosensitive region, we have two key landmarks.
We do. The optic disc, or pupilla, is where the nerve fibers gather to exit the eyeball, forming the optic nerve,
Our blind spot.
because there are no photoreceptors there. And lateral to that is the fovea centralis.
This shallow depression is the physical location for our highest visual acuity.
Correct. It's centrally surrounded by the macula lutea, which has a distinctive yellowish pigment.
And this high acuity zone is highly susceptible to degeneration.
It is. Age-related macular degeneration, ARMD, is the leading cause of blindness in older individuals, causing a devastating loss of central vision.
The most common version is dry ARMD.
Which is characterized by slowly progressive lesions, notably the accumulation of fatty deposits called drusen-focal thickenings of that critical Bruch membrane.
And then there's wet ARMD.
A more aggressive complication. It involves pathological neovascularization, where fragile new blood vessels sprout and leak fluid and blood beneath the retina,
Causing rapid vision loss.
and scarring. The standard of care today involves targeting those leaky vessels with repeated injections of VEGF inhibitors.
Now we have to tackle the retinal masterpiece, the organization of the neural retina into its 10 distinct layers.
And we should just take a moment to appreciate that modern medicine lets us view this in vivo.
Right, with spectral domain optical coherence tomography, or SD-OCT.
It's a non-invasive technology that lets clinicians visualize all 10 retinal layers using reflected infrared laser light, providing a high-resolution cross-section, like a histological slice, but in a living patient. It's invaluable.
Okay, let's begin our walkthrough, starting with the outermost layer, right against the choroid.
Layer 1, retinal pigment epithelium, RPE. This is a single, simple, cuboidal cell layer resting on the Bruch membrane. Their apical surfaces have these complex processes that reach out and surround the tips of the photoreceptor cells.
And the RPE is the true metabolic linchpin of the whole visual system.
It is. Adjacent RPE cells are linked by very tight junctions, establishing the mighty blood-retina barrier.
And beyond protection, it has huge functional responsibilities.
It absorbs stray light with melanin. It's essential for recycling visual pigments, and it functions as the eye's continuous waste management system, performing relentless phagocytosis of the millions of shed membranous discs from the photoreceptors.
Okay, layer 2.
Layer 2, layer of rods and cones. This layer consists of the outer and inner segments of the photoreceptor cells stacked tightly together.
Layer 3, outer limiting membrane. This is a frequent source of confusion because it's not a true membrane.
It's not. It's formed by a series of specialized adhesive junctions, the zonuli adherentes, between the molar supporting cells and the photoreceptors. It acts as a metabolic gate.
Layer 4, outer nuclear layer. So this is where the cell bodies and nuclei of the rods and cones are.
Correct. Rod nuclei are smaller and densely packed. Cone nuclei are larger and lie a bit closer to the layer of rods and cones.
Layer 5, outer plexiform layer. Plexiform means networking. This is the first major synaptic zone.
Right. It contains the processes of the rods and cones where they connect with the dendrites of horizontal, amacrine, and bipolar cells.
Layer 6, inner nuclear layer. This complex layer houses the cell bodies of the horizontal cells, amacrine cells, bipolar cells, and the specialized inner plexiform cells.
And crucially, this layer contains the cell bodies of the Muller cells. These are the primary neuroglial supporting cells of the retina, providing structural scaffolding.
Layer 7, inner plexiform layer, the second major synaptic zone. A massive amount of visual processing happens here.
It's packed with synaptic connections between the axons of the bipolar neurons and the dendrites of the large ganglion cells.
Layer 8, ganglion cell layer. This layer has the large cell bodies and nuclei of the ganglion cells. Their axons are the ones that have to form the optic nerve.
And this layer is thickest at the macula, where visual resolution is highest. The convergence ratio there approaches 1.1, preserving individual receptor input for incredibly high visual resolution.
Layer 9, layer of optic nerve fibers. These are the non-myelinated axons of the ganglion cells running horizontally parallel to the retinal surface as they gather to exit the eye at the optic disc.
Right, and the superficial capillary network of the central retinal vessels is predominantly located here.
And finally, layer 10, inner limiting membrane, the innermost boundary defined by the basal lamina of the Mueller cells.
A key clinical condition here is the development of an epiretinal membrane, or macular pucker, caused by the proliferation of cells on this membrane, which then contract and distort the retina.
So to truly appreciate sight, we need to focus on layer 2, the rods and cones. The numbers are staggering.
They are. We have about 120 million rods compared to only 7 million cones.
Rods are cylindrical, and they dominate the peripheral retina. They are the workhorses of low light detection, enabling our night vision, but they only produce gray tones.
Their visual pigment is rhodopsin. Cones, on the other hand, are conical and are packed tightly into the fovea centralis, where they achieve maximum acuity. They are far less sensitive to low light, but are uniquely responsible for color detection.
And they come in 3 classes, L, M, and S for red, green, and blue light.
Roughly, yes. Their visual pigment is iodopsin.
And the difference in their disc organization is fundamental to how they work.
It is. In rods, the hundreds of membranous discs are entirely enclosed compartments. They're shed continuously from the tip, usually in a big burst after you wake up, and are immediately phagocytosed by the RPE.
And in cones.
In cones, the discs retain their continuity with the plasma membrane.
So since we are on color, let's talk about color blindness. This is when one of the cone classes is missing or non-functional.
Correct. The 2 most common types are protanopia, lacking the L or red cones, and deuteranopia, lacking the M or green cones.
And both are sex-linked.
Yes, because the genes are carried on the X chromosome, so males are disproportionately affected. The main issue is distinguishing red from green.
Now for the highest level concept, the visual processing cascade. The conversion of light into an electrical impulse.
Which is famously inverse. Light causes hyperpolarization, not depolarization.
Okay, let's start in the dark. The chroma-4 retinal is in its inactive form, 11-cis retinal.
Right. And in this state, the photoreceptor cells maintain high intracellular levels of cGMP. This high cGMP keeps the Na plus ion channels open.
The influx of sodium causes the membrane to depolarize, and this depolarization leads to a constant, steady release of the neurotransmitter glutamate.
That's the dark signal. Now, when a photon of light hits the cell, 11-cis retinal immediately changes shape into all-trans retinal.
Bleaching.
This activates the optin protein, which then interacts with a G protein called transducin.
And transducin activates an enzyme that rapidly breaks down cGMP.
Right. The immediate drop in cGMP causes the Na plus ion channels to slam shut. The influx of cations stops instantly, and the cell membrane becomes hyperpolarized.
This hyperpolarization causes a sharp decrease in the release of glutamate.
And it is this decrease of the inhibitory signal that the bipolar cells interpret as the actual nerve impulse, the detection of light.
And for the cell to be ready again, that all-trans retinal has to be reset.
And it's transported to the RPE cells, again, highlighting their vital role, where the RPE65 enzymatic complex converts it back into 11-cis retinal, which is then recycled back to the photoreceptor.
Let's look at the remaining structures, starting with the vessels of the retina.
We mentioned earlier that the central retinal artery and vein enter the eye at the optic disc. They branch out to supply the inner retinal layers, specifically layers 6 through 10.
And a critical anatomical point is that these vessels are anatomic end arteries.
No anastomosis, so any blockage leads to immediate localized tissue death.
And conversely, the outer retinal layers, 1 through 5, including the photoreceptors, are nourished exclusively by diffusion from the choriocapillary layer of the underlying choroid.
This fundamental division of blood supply is the key to understanding so many retinal diseases.
Next up is the crystalline lens.
A beautiful, transparent, avascular biconvex structure. Its job is purely to transmit light and adjust focus.
And it has 3 distinct parts. The exterior is the lens capsule.
A thick, elastic basal lamina.
Yeah.
Inside that, covering only the anterior surface, is the subcapsular epithelium.
And as those epithelial cells migrate to the equator, they differentiate.
Into the third component, the lens fiber cells. They elongate dramatically, losing all their internal organelles, including their nuclei, and become densely packed with proteins called crystallins.
And with age, the lens loses its elasticity,
which causes presbyopia, why many of us need reading glasses. And when the crystalline proteins become altered or cross-linked, the lens loses its transparency, resulting in a cataract.
which is treated by surgically replacing the opaque lens with a clear plastic one.
A highly successful procedure. And finally, we have the vitreous body,
The transparent, semi-solid gel that fills the large vitreous chamber, mostly water, but stabilized by collagen and hyaluronan.
Our journey ends by looking at the supporting cast, the accessory structures of the eye. The eyelids are complex protective folds of skin containing a flexible support structure, the tarsal plate,
And they have two primary muscle systems, the orbicularis oculi for closing the eye.
and the levator palpebrae superioris for opening it.
The eyelids are also packed with specialized glands. The tarsal glands, or meibomian glands, are long sebaceous glands in the tarsal plates.
Their oily secretion forms the outermost layer of the tear film, which retards tear evaporation. A blockage of these glands causes a localized swelling called a chelation.
And if the sebaceous glands of Zeiss in the eyelash follicles get a bacterial infection,
That's a painful swelling called a stye, or hordeolum.
the inner surface of the eyelids and the anterior sclera are protected by the conjunctiva.
A thin, transparent mucous membrane, with abundant goblet cells that contribute the mucus layer to the tear film.
An inflammation of this membrane is conjunctivitis or pink eye.
Right. Bacterial conjunctivitis typically causes a thick, purulent discharge and needs antibiotics. Viral conjunctivitis is more common in adults, presents as diffuse pinkness, and is usually self-limiting.
Finally, the lacrimal gland and apparatus.
The lacrimal gland itself is a large serous gland that produces tears, which are rich in antibacterial agents like lactoferrin and lysozyme.
And tears drain across the cornea into the lacrimal puncta, then the lacrimal canaliculi into the lacrimal sac.
And from the sacs, they descend through the nasolacrimal duct to empty into the nasal cavity.
And we circle back to the engine of coordinated movement, the 6 extraocular muscles.
Their precise symmetrical action is controlled by 3 specific cranial nerves. Cranial nerve the 5th for the superior oblique, cranial nerve the 6th for the lateral rectus, and cranial nerve 3rd for all the rest. Their perfect coordination ensures we maintain a parallel conjugate gaze.
So we have journeyed through every layer of this remarkable sensory apparatus.
And we've confirmed that sight is a function of 3 perfectly integrated coats. The tough, transparent corneoscleral coat, the nutritive and light-absorbing vascular coat, and the complex 10-layered sensory retina.
And we've highlighted the extreme specialization required for sight, from the precise orthogonal array of collagen for corneal transparency, to the avascular lens, to the retina's division of labor.
And we really zeroed in on the retinal pigment epithelium, understanding that it's far more than just a simple barrier. It is a metabolic bridge, the waste disposal system, and the crucial recycling plant for visual pigments.
So, as a final provocative thought, we ask you this, building on that critical relationship between the photoreceptors and their support system. Given the intense, constant metabolic demand of the photoreceptors and their absolute reliance on the RPE to ferry nutrients across the blood-retina barrier from the choroid, how might common systemic metabolic diseases like diabetes pose a disproportionately high risk specifically to the outer retinal layers, layers 1 through 5, before they significantly affect the inner, directly vascularized layers?
A fascinating problem to consider, rooted entirely in the compartmentalized histology of the eye.
Indeed. Thank you for joining us on this incredibly dense deep dive into the histology of the eye. We hope you feel thoroughly equipped with the necessary knowledge.
Until next time, keep exploring the layers beneath the surface.